Everybody, welcome back to another series here on our YouTube channel. This is a new series that we have for January 2024, and it is going to focus on all of these various care practices around HIE and cooling. And so our first presentation, we have Dr. Alfonso Vargas, who is a neonatologist from Tampa, Florida, and he is going to be presenting to us the Maybe Baby care protocol that he and his team put together for their hospital. The Maybe Baby is that mild HIE baby who doesn't quite qualify for cooling based on our traditional criteria for hypothermia for the moderate or severe encephalopathic babies. So what do you do when you're faced with a baby who doesn't quite meet those criteria? Dr. Vargas presents a systematic way of approaching these babies, assessing them, and doing a team huddle at the end of the 6 hours to make that final determination and allow the entire team to participate in that decision. It is an amazing presentation from our 2021 conference in Orlando, Florida. It was that last conference we did right before the pandemic, and I know that you're going to enjoy this replay. So if you haven't already subscribed to our channel, it really helps us out a lot. And of course, if you enjoy this presentation, give it a big thumbs up. It tells the algorithm that you like videos like this and helps us to grow our channel. Also, if you would like to get some of the resources related to Dr. Vargas's presentation, go ahead and either scan the QR code here on the screen or look in the show notes below and click the link that says to download the slides and other resources. So without further ado, I hope that you enjoy this presentation by Dr. Alfonso Vargas from our 2021 conference in Orlando. And I'll see you at the end.
I'm going to talk about the Maybe Baby. So by Maybe Baby, I'm referring to more of our mild HIE kids. What do we do with those kids? We'll go over some of the growing body of evidence that mild doesn't necessarily mean benign. Some of our learning objectives, so we're going to look at some exam criteria that qualify babies for hypothermia, so we'll just kind of quickly review some of that. We're going to define mild hypoxic ischemic encephalopathy, so we'll kind of look at our SARNAT scoring and what that means. We'll talk about our Maybe Baby tool, so our binder, which I'll show you and we'll go through. And then at the end, we're just going to look at a couple of case scenarios where we applied our binder and how that affected our clinical decision-making and our management of these babies. I have nothing relevant to disclose. I like to start usually by talking about something that we as neonatal providers oftentimes don't think about, and it's what happens after they leave our NICU. In our NICU, when you look at the healthy baby and then you look at the hypoxic ischemic encephalopathic baby, they may look very similar side by side. They're dependent on their parents, they're dependent on us, they're fed by others, they're dressed by others, their toileting needs are met by others, and that's no different from one baby to another. They leave our NICU, you fast forward several years, that's where you really start to see the big differences. So our healthy neonate is going to become more independent, is going to learn to feed him or herself, dress him or herself, toilet him or herself. That HIE neonate, they may stay in that state where they were where they were when they were in our NICU under our care. So I think we as neonatal providers are in a very unique, privileged position to really impact 70, 80 years of a person's life. All right, so that's a privilege that we have, and it's something we need to think about in our day-to-day care, because very seemingly little decisions we make can have long-lasting impact on these babies. And as kind of the focus of this talk, we sometimes, or we have thought about mild HIE as being fairly benign, but as we are starting to learn more and more, and there's more and more, again, body of evidence, those mild HIE babies can still have pretty significant long-term neurodevelopmental delays and poor outcomes. And what do those look like? So what do those patterns of impairment look like? Motor disability, cerebral palsy, they can have cognitive and learning issues, speech and language problems, behavioral issues. So there's a myriad of things that these babies can present with that require not only more intervention, more time from their family, but also utilization of resources in the community. So we have to protect, this is why we're all here. We want to learn how to better protect brains, how to get that baby into a better outcome, and how do we get that baby to be more like that healthy child versus the impaired child. And there's a lot that we can do to go in that direction. So as far as hypoxic ischemic encephalopathy, I know this is a review, but we'll just go real quick. So the HIE really refers to more of a pattern of behavior or a clinical appearance of a baby that is a result of some sort of hypoxic or ischemic injury. So at baseline, this is either a baby who has had lack of blood flow, lack of oxygen, all the things that follow that lead to this clinical presentation that we refer to as HIE. It occurs in about 1 to 6 per 1,000 live births, and the risk of death or severe disability in the moderate and severe categories of HIE is very high, so as high as 60% in the literature. And again, there's just long-term neurodevelopmental sequelae related to that. When we look at the SARNAT staging, so this is, again, how we're clinically classifying these babies, we're pretty familiar with what this looks like, and we know we've got the mild, the moderate, and severe. And when most of us look at our cooling protocols or guidelines, and you look at the studies that got us where we are today, our focus has always been the stage 2, stage 3. So the moderate and the severe category HIE babies are the ones we've really focused all of our efforts on in terms of treating. And what I'm hoping, most of us are becoming more and more aware of, those stage 1 babies also need our attention and need our care, and we will be probably very soon developing more standardized guidelines for what to do with those babies and how to evaluate them. So just to tell you a little bit about where we're coming from, and this kind of goes into then how we developed our process. St. Joseph's Women's Hospital in Tampa, we have a level 4 NICU. Currently we have 64 private rooms. That's kind of the entrance back into our NICU. We have 32 beds on one floor, 32 beds on the floor above that. It looks exactly the same. Everything's kind of organized by neighborhoods. We have 4 neonatologists rounding every day. We are not university affiliated, so we have medical students, we don't have residents, we don't have fellows. So it's very much a private group. We usually average about 1,000 to 1,200 NICU admissions per year, and we started our cooling program 7 years ago. So in the fall of 2012, we cooled our first baby. Since then, we've cooled about 100. Are we still at 105? All right. I want to make sure you were getting the exact numbers. When we started our cooling program, we did decide we were going to partner with our larger teaching institution here in Florida, and that's University of Florida. So at Shands in Gainesville, Dr. Weiss had started this FN3, the Florida Neonatal Neurologic Network, which Kathy mentioned a little bit earlier. And they had already developed protocols and guidelines for cooling for the state of Florida. The amount of partner hospitals has increased over the years. So you see there's various hospitals around the state now that participate in this research registry. So the nice thing about that is, A, they had already developed protocols and guidelines based on the NICHD cooling trial, so we didn't have to reinvent the wheel. We basically just kind of partnered with them, took what they were doing, and now we're part of a larger registry where all of our data gets pooled together with the other cooling hospitals around Florida, and we're looking at different biomarkers, we're looking at MRI scores, we're looking at how these babies are developing 2, 3, 4 years down the line in terms of their developmental scores and indices. It is a centralized registry, and we send all of our demographic data, MRI data, clinical data, as well as tissue and blood samples up to Gainesville, where all these things are looked at. So it is a statewide network. Again, our protocol with FN3 is based on the NICHD whole body cooling protocol, and we meet annually. So we have telephone meetings every few months, but once a year we meet here in Orlando, and we kind of plow through our protocol, our guidelines. We look at the evidence, what new things are out there, what do we need to change, and then we all kind of agree, and then those new protocols get released to all the sites around the state. I'll quickly plug the website because it is a very nice resource for clinicians. It's hopefn3.org. When you click over where it says providers and education, you'll see there's a host of stuff. So everything that we put together is available publicly. There's SARNAT certification information. It includes some video just going through a SARNAT exam. There's also, how to set up cooling. There's a predictor calculator for HIE, and our protocols and guidelines are there as well. If you click there, you can freely access those. So it is a very good resource that you can utilize. When you get some downtime, you can kind of look through this, and there's a host of really good information. So how do we cool it? This is not how we cool. This is the cheaper way to do it. I have no idea what's going on in that picture, but it's just an awesome picture. But what we do at St. Joe's, so our protocol again is greater than or equal to 35 weeks. We will cool babies under 35 weeks if they're over 1.8 kilos. So we use weight a little bit more heavily weighted than the gestational age alone. Again, less than or equal to 6 hours since the injury. And then when you look at our biochemical criteria, this is all pretty standard across the board in terms of, I think, what most units are doing. From a encephalopathy standpoint, so like once we're looking at our exam, again, you see the mild is left off, and that's pretty much across the board, right? So we're only cooling moderate and severely encephalopathic babies. So that leaves our mild babies kind of like in this lurk where, again, we now know maybe it's not so benign, but again, it's not part of the inclusion criteria at this point for cooling. So what are the challenges? And I know this probably applies to most places. The neurologic exam is dynamic. It changes over time. You can have a baby who at an hour looks great, 2 hours doesn't look so good. So that there has to be continuing evaluation of that child because it is changing. And we want to capture that if it does change because they may qualify for cooling at a later time. There's significant inter-observer variability. So if I go in and see a baby, I might think the tone looks good. The person next to me might think the tone's a little bit low. So there's a lot of subjectivity to how we assess babies and therefore how we determine whether they're mild, moderate, or severe. So again, I think one of the things that we've tried to do in order to reduce at least that part of it, that variability, is to have most people on our cooling team, our nurse practitioners, cooling nurses, respiratory therapists that are involved on transport. We have them undergo a SARNAT certification where, again, as part of the HOPE FN3 website, you can see kind of what that process looks like, but we have everybody certified, and then we have like somebody who is determined as like a gold star examiner verify that person is actually performing a good SARNAT score so that there's less, again, variability if different people are doing the exam. And I think over time, what we have really noticed is our bedside nurses and clinicians who are taking care of these kids have become very good at performing these exams. Not all of our hospitals have NICUs, so in our particular situation, we cover 4 different hospitals, 3 of which have NICUs. Only one of those has a cooling setup, so it's a little bit different. We have to think about, again, just looking at our own challenges, what are the things that we have to overcome as a group, or what are the limitations or obstacles potentially to really deploying a very robust evaluation process for these babies? And you will have to look at your own units, at your own practices, and figure out, what are the limitations or what are the obstacles that we have. But for us, that was a bit of an obstacle. How are we evaluating babies, in the hospital where we don't even have a NICU? How are we evaluating babies in the 2 NICUs where we don't have cooling because we don't have AEG there either? So those just kind of pose different problems that then you have to figure out how you're going to account for those or solve them. And then the other challenge was this Monday morning quarterbacking. We've all had that situation where you come in, the decision's made not to cool a baby, seizes later, and then the next day everybody's like, well, I would have cooled that kid. Well, you weren't there, so how do you? So that's a huge problem, right? And so one of the reasons we came up with this tool that we're going to go over is we wanted to eliminate that as much as possible, right? I think most of us probably feel this way. I've never regretted cooling a baby. I have only regretted not cooling a baby, all right? So I think most of us feel that I would rather cool more babies than is necessary, again, because it's so safe, than miss that one kid that seized at 12 hours of life, and then you're kicking yourself wondering, what did I miss? What could I have done differently to identify that baby and qualify for cooling? So now the big question is, how do we address mild HIE then? Or why even worry about it? Well, first of all, there's no currently accepted guideline or uniform standard or gold standard for what to do with mild HIE. So why worry about it? 2 things happen before this comes up. When you Google mild HIE, probably the first 2 pages you get is lawyers, all right? It's lawyer websites. So we have to realize that we practice in a very aggressive medical legal environment. We have to protect ourselves. So I think part of developing a strategy is, we want to do what's best for the babies, and we want to make sure we're not missing kids, but we also have to protect ourselves and have something that we can utilize to say, hey, we used this process, and this is why the baby didn't qualify for cooling, and that has to be well documented. All right, but besides all the lawyer websites, you start to get tons and tons of new data that's coming up. It seems like almost every month there's new information about the adverse neurologic, the abnormal MRIs, the long-term neurodevelopmental delays associated with mild babies, okay? So some studies report that they do as bad as moderate babies, okay? So their outcomes are not good. So we do have to come up, and there are current ongoing studies that are recruiting patients, so I think we're going to have an answer soon, but in the meantime, I think it's important for us to, as individual units, figure out how we're going to address this problem. So the FN3 developed this, and I apologize that it's very small, but it should be in your handout. The FN3, we put together this list about 2 years ago as a recommendation for our sites for how to evaluate the mild baby. So the top of this sheet is basically just our regular cooling qualifications, right? So gestational age, weight, our biochemical criteria. So really what the rest of this is aimed at is those kids that meet biochemical criteria maybe, but their exam is not at a moderate or severe stage yet. Okay, so how do we look at those kids? So the first recommendation there is serial neurologic exams. We know that, right? We have to perform them hourly. So there is a recommendation every hour, perform the exam, because you don't want to miss that kid. Again, it's a dynamic exam. You don't want to miss that baby that all of a sudden became moderate at 4 hours, but at 3 hours looked fine, so you wrote them off and said, we're not going to cool. So there has to be serial exams. Now, when we looked at our unit, again, we don't have med students, we don't have fellows, we don't have residents. So one of the challenges for us was, well, what if I admit a kid, they're mild, I have every intention to go back and examine that baby every hour, but then all of a sudden I get this other delivery, I gotta go put in a line, somebody self-extubated, and by the time I look at my clock, it's been 3 hours, and I haven't gone back to see the baby. So we didn't really have a good process in place that held people accountable to go back and actually perform this exam. So again, that was one of our challenges. Where do we put them? Do we put them in a nursery? Do we just say, hey, I don't have a cooling program at this hospital. If I get a mild baby, do I have to send them over to the other hospital where we do cool for them to do the AEG, do the serial exams, and then decide if they're gonna cool, and then if we don't cool, they just ship them back. So we did have to come up with some solutions based on what our system looked like, okay? So again, I think a lot of what you do has to be tailored to what your particular unit setup is and what your particular challenges are. The second point there is monitor temperature. We don't want these babies to become hyperthermic, okay? We don't want to passively cool them. We haven't pulled that trigger. We haven't said we're going to cool. But while we're evaluating and while we're waiting to see what we decide to do, we definitely want to avoid hyperthermia. So that's important as well in terms of outcomes. And then we came up with some labs that might be helpful. And again, this is evidence-based, not a whole lot of this. There's nothing cut and dry about, oh, my lactate came back high, we're going to cool. I think what these labs help us do is just put more pieces to the puzzle, okay? So what the lab that we usually use as the most sensitive indicator is going to be our troponin. So we do send, if you look there, we send LFTs, we send the troponin and CK, we get a lactate, we send coags, and then we go online and we can pull up the FN3 website and calculate an HIE score, which will sometimes help us make decisions, and then we put on the AEG monitor. All right. So for the big trials, for the NICHD trial, and subsequently for our protocol, we don't use AEG as criteria, as part of our criteria to include a baby or to cool a baby, but we do use it for mild babies now as a screening tool. Again, it's just more things that you can look at, and if it's a baby who you're a little worried about, may not meet exam criteria, may be mild, but your AEG is abnormal, that might be what helps me pull the trigger and say, okay, we're going to cool this baby. Our AEG is not normal. And then you can look at those labs. As those labs start to come back, and we do recommend getting them at an hour, that gives you plenty of time once they come back to still be within your cooling window, right? If you wait too long, then you may not get the results back in time. So we send those labs, we continue monitoring the baby, examine the baby, put the AEG on, and that gives us a little bit of time to start formulating a plan and come up with a decision, okay? So that's kind of our approach. That's what the FN3 had recommended. And again, we come back to our unit and say, okay, this is the recommendation. How do we apply this given our particular setup, given the NICUs we cover, given the staff we have? How does this make sense for us? We went back and looked through the University of Florida cooling data just to see what's been happening. Again, with this increased awareness of the long-term issues associated with mild HIE, kind of wanted to see what's been happening over the past couple of years in terms of who we're cooling. And you can see between 2017 and 2019, the number of mild babies went from 4 to 6 to 14 in the span of a few years. And I think a lot of it just has to do with, our now understanding that those babies do have abnormal long-term outcomes, and the fact that I think we're just screening them a little bit better, okay? So it is a trend, and I think that trend is just gonna continue. So what we did was we took the recommendations from the FN3. We have an amazing group of cooling nurses that really kind of took on a project to come up with a binder. So this is one of our actual binders. We just put it at the bedside, and I'm going to show you the contents and how we use it. But what this was meant to do was address this issue for our unit. It's how are we going to evaluate these babies? How are we going to make sure we're not missing kids, right? So And I'll show you each one of these individually so you know what they look like. But in the binder, we've got the admission checklist. We've got a SARNAT worksheet, which I'll show you. The SARNAT scoring tool just meant as a refresher while you're there examining, again, in an effort to reduce variability. We've got a timeout huddle flow sheet, which I'll explain and I'll show you. We included the cooling guidelines from the FN3, so they're there. You can pull them up and look at them. We included management of outborn infants because, again, 3 of our units don't have cooling capability. So for those units, the instructions are a little bit different, how to prep the baby, how we start to passively cool, what are we doing to monitor temperature, things of that nature. So what to do if you're in one of those hospitals. We've got our mild HIE recommendations, so again, the sheet from the FN3 with the labs that we need to draw, because if you're in an outside hospital, one of the things that you can get rolling while you're waiting for the transport is you can go ahead and send those labs. That way, when the baby arrives to the cooling facility, they've already got results, and we can start, again, formulating decisions as quickly as possible. And then we've got the screening neuro exam PowerPoint slide. So it's basically like a little picture PowerPoint presentation showing a SARNAT exam. Again, we want to reduce inter-observer variability. The admit checklist is here. Again, I apologize for the size. I tried to get as much of this as I could in there. So this is the first, and these don't, by the way, this does not become part of the medical record. This is basically our tool to use and make some decisions. But we've got several goals on there. The first one being to prevent hyperthermia. So it tells you, what to do, where to place the baby, what to set the servo control at, temp probe, and documenting temperature every 30 minutes. That way we know we're keeping that baby from becoming too warm. It's got the list of labs that we need to send. So it's got the labs that we need to obtain within an hour of birth. And then it's got check boxes for 6 or 7 actually SARNAT exams. So we go through, make sure we're doing it every hour. And again, when it's part of a checklist and you've got a team looking at this, not just 1 or 2 individuals, it's much more likely to adhere, and you'll get a reminder, hey, Dr. Vargas, it's been an hour, can you come look at the baby? So it's more of a team effort than relying on one person to remember or to come back and do the exam when it's time. An hour passes really quick. I mean, you guys all know that in the NICU. Then we want to monitor electrographic brain activity, so we place the AEG. And again, it's not part of our inclusion criteria, but we use it a lot now when we're screening these mild babies, and it helps us push us one way or another. Okay, it's very reassuring when it's normal. If it's anything but normal, then that kind of gives us a little bit of food for thought. And it's also important, as was mentioned earlier, we have to make sure that we're thinking of other causes besides HIE. Okay, so we have to think, clinically, is the baby behaving a certain way that may not be consistent with HIE? And actually, one of our cases we'll go through will address that issue. The next sheet is actually the exam worksheet. So this is meant to be filled out by the provider who's actually doing the SARNAT exam. So there's space there to go each hour. Again, you go through, you document your exam findings, and at the bottom, it's asking you if the baby has seizures, is the baby mild, moderate, or severe, and at that point, does the baby qualify for cooling based on exam findings? Okay, so that's just based on exam. And this is filled out through the 6 hours. You have a little space there to put comments if you need to add anything that's pertinent to the decision-making for that baby. We include the SARNAT scoring tool, again, as a refresher for the person who's doing the evaluation. We want to make sure that, if you're not doing that often, that you go back and actually look so that you're scoring it as adequately as possible or as reliably as possible. And then we've got the huddle flow sheet. So this is where we really prevent most Monday morning quarterbacking. So you can see at the bottom left here, to your left, there's a lot of people that need to sign off on the final decision that's made, or a lot of people that participate in that decision. So we include everybody who's a member of the team can say, hey, I think this baby is a maybe baby, can we start evaluating? Anybody can suggest that we apply this process. And then while we're going through the process, everybody's got to I'm not saying that we're all in agreement 100% of the time, but we have to have a discussion, right? So it's important that everybody who's taking care of the baby has an opportunity to raise their concerns, to, again, have a discussion, and that all helps us make a decision together. But once you've signed off on your final decision here, you see there's 3. Team agrees that the baby meets criteria for cooling based on our protocol. That's the first one. The baby does not clearly meet criteria for cooling under our protocol, but the decision is made as a team to provide cooling based on clinical judgment. Or the third one, which is the team agrees that the baby does not clearly meet criteria for cooling, and at this point we have decided not to cool. So once the team's in agreement, we've all had a chance to discuss our lab results, what the AAG looks like, what our clinical exam is looking like, then we kind of make a decision and say, as a team, we've decided we're going A, B, or C. All right? So that really helps promote a good team culture, but I think it's also better for the baby because you've got a community approach to making this complex decision. So we developed, like I said, the binder. We decided we're going to put it in all of our NICUs, so it's at all of our facilities, so our providers all know what it looks like, our NNPs know what it looks like, our nursing respiratory therapists, again, all participated in developing it, so everybody knows where it is and how to use it. So we put it in our NICUs. Everybody's educated on how to use it and on the purpose of it. And like I mentioned before, anyone can suggest a baby be evaluated as a maybe baby. And the thing that was a challenge, again, for us was only having one cooling center but 3 NICUs and 1 nursery, was what do we do with those babies that are at facilities where we don't necessarily have in-house coverage or where we don't have AEG monitoring? And that took talking to administration and saying, we may sometimes have to eat the cost of a transport, but it's the best thing for the baby. If we're concerned about a baby who could potentially need cooling, I'd rather get the kid over here now rather than, oh my gosh, the kid seized at 6 hours, now we're behind the 8 ball. So it's better to get those maybe babies over to our main facility, evaluate them there. We can do all the SARNAT scoring, we can do the AEG, and then the administration is well aware, our administration is aware that if that baby then does not qualify for cooling, then at 6, 7 hours of life, if the baby's otherwise stable, we can send them back so that there's not that prolonged separation from the parents. Okay, so there's drawbacks to doing it, separating from the mom, et cetera, but we try to come up with some creative solutions that allow us to provide the best possible care for the babies and at the same time use our resources as best as we can. So we'll cover a couple of case scenarios here and then hopefully have some time for some questions. So this first case, we've got a 35 and 5-week baby, stat C-section for non-reassuring fetal heart tones. Mom, 39 years old, G1, GBS unknown. She'd been admitted multiple times during this pregnancy with hypertension. She'd actually received steroids at 32 weeks. And this time around, she was on MAG for neuroprotection and hypertension. The baby came out pretty limp, apneic, was bradycardic. It got intubated and positive pressure in the delivery room, but you see the 5-minute APGAR already would not meet criteria for cooling. So biochemically and by APGAR, looking like this baby resuscitated fairly well. You look at the cord gas, again, not impressive. It's not going to meet biochemically our criteria for cooling, but the baby was encephalopathic appearing, right? Was limp, was apneic, was needing respiratory support. And you see here the sheet that was filled out for that baby. Again, we go through preventing hyperthermia, obtained all the labs, started our serial SARNAT scoring, put the AEG on the baby, and then again, considering other causes of encephalopathy. And in this kid, you start to think about, is this MAG exposure? What else could be contributing to this baby's encephalopathic appearance? So then we move on we start getting the labs back. The labs all looked essentially pretty normal, except the magnesium, which was 6.7. So this kid was like just really magged out. But we still felt that this kid needed to be monitored in case, again, given the resuscitation, in case at any point maybe we thought the baby did qualify for cooling. So what you'll notice is on our flow sheet here, in the first 2 exams, they actually tick the box for, yes, does qualify for cooling based on exam criteria. But because we had other information coming back, we put the AAG on, which was completely normal on this kid. We knew what the MAG level was. We thought, well, let's continue to screen. That way we've got a few hours to still make a decision with the baby, but we're still treating it as a potential cooling kid. So we've got more frequent vitals, we're monitoring the temperature, we're doing other things that we would do potentially for cooling baby, and just kind of screening this baby aggressively. And then what is at 3 hours of life, you go from 4 to 3, you went from 4 to 3 indicators of moderate encephalopathy on exam to 2 to 1 to 0. So that this category here where you had 4 moderate indicators of encephalopathy continued to improve over time. The exam improved over time. And then already by hour 3, clinically was not meeting criteria. We got our lab information back. We had a normal AEG tracing. So the huddle is done. Everybody who's there agrees. Tick box number 3. We looked at this baby, evaluated it using our protocol or our guidelines, and decided this was not a cooling candidate. all right? So that was kind of going through one case. Another case is this term baby, so 39 and 3 weeks, a baby boy, another section for non-reassuring fetal heart tones after a failed induction. Mom's a 36-year-old G1, GBS negative. She had very severe anxiety prior to the delivery, and she was given a dose of propofol. Similar to our last kid, this baby came out limp, apneic, was not bradycardic, but did require PPV and CPAP. Again, you look at the APGARs, and they improved. So when you look at our inclusion criteria for cooling, with that APGAR of 8 at 10 minutes won't necessarily meet cooling criteria. And then the cord gas is kind of borderline. So you've got a 7.0 with minus 11 base deficit. So that kind of puts us in a little bit of an at-risk zone. So this baby, again, was put into our process, identified as a potential maybe baby. And what you'll notice here is, again, when you hear the history and you start to think about what are the other potential etiologies for this baby's clinical appearance, the big elephant in the room was the propofol. So we thought, okay, well, maybe the kid just needs to wake up a little bit. But again, based on the clinical appearance of the baby and the acidosis, we felt like it warranted a little bit closer evaluation. That's not a baby we wanted to just kind of ignore, leave by the wayside. So again, start to fill out that SARNAT scoring. And what you'll notice is there was a thought initially that, yeah, meets criteria for cooling by exam, but at the same time, we're thinking, well, maybe it's the propofol at making the baby look like this. Then you've got, over time, at the 1 hour mark, all of a sudden your indicators went from 4 to 0. So this baby looked really good, looked great. And so you're thinking, okay, we're free and clear. And what I hate to think is what would have happened if we stopped at that point, if we stopped looking, right? Because at the very next hour, that exam changed again. All right, so all else being the same, that baby again started to develop more signs of encephalopathy. AEG still looked okay. The lab started to come back, looked essentially pretty normal, but our exam changed. So at that point, the team gets together and they say, you know, it's now 9:47. This baby now does meet criteria for cooling based on our biochemical information as well as the change in the exam. All right, so this allowed our team to monitor this baby a little bit more closely, capture it at 4 hours of age as a cooling candidate, and cool the baby. And again, these are the kind of situations which were, in the past, I always worry, if we didn't have a process in place, would we have just kind of forgotten to come back and do the exam? Not because we didn't want to, but because you get busy, you're bogged down, time goes by, and you don't realize. But when you have a process in place, it really kind of helps hold you accountable and your team accountable to make sure that you're doing everything you need to do to screen those babies. I think this was within 1 or 2 days of us putting this binder out. You build it, they'll come. That's exactly what happened with this binder. So within a couple of days, we're like, wow, this process is actually pretty neat. It helps promote like that kind of team mentality, that cohesion, and really helps us make a decision in babies that are otherwise kind of in a gray zone. So what are the key benefits of our Maybe Baby binder? Increasing ability to capture at-risk infants again. So when you go back to that slide about regretting not cooling a baby, that's what we want to avoid. We want to make sure we're capturing as many babies as we can. We want to avoid those misses. We want to increase awareness of at-risk infants and ensure that they're getting appropriate short-term follow-up, so that key 6 hours where we're still within that cooling window, we want to make sure that we're doing everything we can do to capture babies that may otherwise be missed. We've worked on decreasing inter-observer variation in neurologic exams. So part of the Maybe Baby binder, like I mentioned, is that SARNAT scoring certification. We've been working on that across the board in our unit to try and get as many people comfortable with performing a SARNAT as possible and competent at it, so that if you have 3 people going in, hopefully we get 3 very similar scores. And we want to promote team culture and team involvement, and I think that's another key benefit to this is everybody on the team is getting better at identifying these kids. Everybody on the team is getting better at examining these babies, and everybody is participating in the decision to cool or not to cool. Now, the main reason, again, we're all here, is going back to that slide where we had the kiddo that grew up to play baseball. This is actually the first baby we ever cooled. His name's Titan, so he just turned 7, I think, just past November. Kind of like with our binder, we opened our cooling program within a week, we got our first cooling baby, and then it's kind of, sometimes it's ebb and flows, but we get about 20 a year. But he was our first one, and so he's very special to our team because he was our first. He didn't know it at the time. We told him like 5 years after. By the way, when we cooled him, we had no idea what we were doing. That's not something you tell them when they're in your unit. But it was, we got the baby. We're like, oh, we think this kid qualifies for cooling. And then I'm on the phone with Dr. Weiss. I'm like, oh my God, I think we got a cooling baby. So hold my hand, walk me through this. Our team was wonderful. And again, we've done a lot of work to get to that point. But it's always when you get that first one, it's pretty nerve-wracking. But anyway, he's 7 years old now. And one of the amazing things about our cooling babies is we keep in touch with nearly all of them. They come back every couple of years for a cooling reunion. We did like a Frozen theme one year. It was pretty funny. We had Elsa coming through, popsicles for the kids. But yes, we kind of make it fun, but we get to see them, and it's pretty amazing to see just how well most of them are developing. And for Titan, for example, when his mom sends us pictures like this of him out on a baseball field, or she'll text Jane and say, Titan hit like 2 home runs today. He's on the All-Star team. He's reading, 2 years above his grade level. We see that as victories for us. So that's like what you guys are doing at the bedside. That's what we're doing is like, so when he hits a home run, it's like we all did. Like we all participated in getting him to that point. So I think what really drives and motivates us, what motivates you to be here at a conference like this, is that willingness to go back to your units, put into practice the things that you're seeing and learning here because of that. So just always kind of keep in mind the reason we're doing these things. I put my email up there. If any of you guys want, we can share what we have. Again, it's adapted to our unit. You can contact me and we can share stuff. And again, you can use it, modify it, do whatever it is. Again, we're all here for the babies, so we're happy to share what we have done if you think it may help you or benefit you. And with that, I think we've got a couple minutes for questions. Or
have you started looking into late cooling up to 12 hours?
So that's one of those topics, again, like cooling preemies, cooling beyond 6 hours, cooling for longer than 72 hours or shorter. Those are all things that are still being looked at. We have not started cooling past 6 hours because I just don't think the data is there showing that there's much benefit yet. But that may be something that changes over time.
Anybody else?
For legal purposes, does your huddle flow sheet become part of the record?
No. This is all maintained. We keep them. It does not go in the chart. So this is just for our use, for our process. Yeah.
I just wondered about qualification for the SARNAT exam. Is that something offered by the state? Is that offered?
So basically how that started is when they were recruiting centers for the initial NICHD trial, Dr. Shankaran, she developed a certification because there were multiple sites admitting babies to the study. So they wanted to make sure that there were certified examiners at each. So she started a process by which they developed this certification process. So when we started our cooling program, we actually, through the FN3, they had a relationship with her. They had started to certify some of their examiners in Gainesville, and we just thought, again, everybody should be doing this, not just centers participating in a trial, because, again, we want to do what's right for the baby. We have multiple people examining these kids, so we decided we would develop a local for us. We have a couple of people that are, myself included, that are gold star examiners, and we can sign other people off. So members of our nursing team, members of our transport team, our nurse practitioners, our physicians can all undergo this process and become certified. And the explanation for how it's done is actually on the FN3 website. So I think if you click on that SARNAT certification tab, it'll kind of point you in the right direction. Yeah. And they're happy to create an examiner for you or assign somebody off that then can help you locally develop more and more certified examiners.
So given that you have about 20 babies a year, do you have a core group of nurses taking care of these babies, or does everyone care for these babies?
We have a core group. So that group is growing. So we started off with a smaller group of core cooling nurses. So we had to have people that were there every shift. So every shift had to be covered. Jane, how many cooling nurses do we have right now? 15 and 15? Yeah. So a total of 30 nurses that are part of our cooling team, and they undergo a little bit more robust education yearly. We have teaching days, their skills sustainment, so there's a lot of ongoing things that they do in addition to what the non-cooling nurses undergo.
Other data that you have been able to track, does that include the length of stay? Are you finding a certain length of stay for these babies? And also, how is the developmental? Are you keeping track of the developmental outcome?
Those are both great questions. So from this standpoint, no, we haven't been tracking length of stay. The only thing we've really looked at, and actually Kathy mentioned it in one of our publications, was looking at length of stay related to feeding during cooling, but not related to this process at all. And then as far as development, we, again, are not a university-based practice. We don't have a set, developmental follow-up clinic. We have a pediatric neurologist that follows up our patients and reports back to us into the registry. But the other feature of our program or of our hospital is that it is a referral center, so a lot of patients aren't necessarily from Tampa proper, so they may be getting follow-up elsewhere. So it is easy for us to kind of lose track of some of these babies, but the registry, because they're part of the Florida registry, the registry does a pretty good job of trying to track most of those kids down, and they report back to us over time what sort of neurodevelopmental follow-up our kids are having. And not just ours, but across all the Florida sites.
I hope you enjoyed this presentation by Dr. Vargas. It was one of our favorites from the 2020 conference, and it is definitely one that I like to revisit over and over again. I love the systematic approach that they put together at St. Joe's that allows them to not only assess these babies, have really good conversations with the family, do serial exams, but to have that huddle where they can actually prevent that Monday morning quarterbacking that he talks about and allow everyone on the team to have input for these very critical decisions. What we do in the NICU, as Dr. Vargas said at the very beginning, what we do impacts up to 70 to 80 years of this baby's life. And so being able to provide the best care and be able to do that in an environment in which there is just great collaboration and teamwork is just such a gift. And we're so grateful to Dr. Vargas for giving us this presentation, for reviewing the literature around the outcomes for babies with mild HIE. We know that this is a complicated conversation, one that has ongoing research and one that we do not have the answers for. So I think that they have done the best that they can, which is trying to assess these babies systematically, have team input, good, clear communication with families, and then reviewing these cases as they're happening so that they can continue to do better. It is such a great model that all of us can follow. And as he said, they are more than willing to share their resources. So definitely reach out to him if you have any questions. I'll put his contact information in the resource area as well. So go ahead if you haven't already, scan that QR code or click the link in the show notes and we'll take you through right to that area. Also, if you haven't already, what are you waiting for? Go ahead and subscribe to our channel. It helps us out a lot. It allows us to bring you more and more free content. So I hope that you enjoyed this week 1 in this series. We'll be back next week with another presentation, and I hope you'll follow along with this cooling series for the whole month of January. It's cool outside, so let's talk about cooling, and I hope that you'll enjoy all the presentations all month from our amazing presenters. We have Dr. Weiss, who's also going to present on MRI. We have 2 nurses who are going to present on bedside care and follow-up and outcomes. It's going to be amazing, and you don't want to miss a thing. Definitely subscribe and hit that notification bell so that YouTube can tell you when we've posted new videos. Thanks so much for being part of our Synapse community here on YouTube, and I'll see you next time. Bye!